Well, hello everybody. This is Dr. Shepard, and we're going to talk a little bit today about the science of early childhood development and what that's teaching us about what we can do with our children and families in our communities. We're going to start with just a picture of the life course health development. And as you can see, what we know now is that things that happen in early childhood carry through and have an impact on the life course of health and well-being for the rest of the child's life. And that trajectory is a balance of risk factors and protective factors, and it starts even before birth. So in Kentucky, that takes us back to the year 2000 when the Kids Now legislation was passed, because as you know, that was really about the science that was out at the time about early brain development. And you can see that in the Kids Now legislation and the Early Childhood Authority, the first four goals were about assuring maternal and child health, strengthening families, enhancing early care and education, and public awareness. And the reason that everything changed was because we suddenly learned that the brain development is flexible and that experiences in early life really do make a difference in the way the brain actually develops. And so some of you may have seen this slide at that time, which the slide on the left is a slide of a normal child's brain, and the slide on the right is the brain of a child who was in a Romanian orphanage and severely deprived of any kind of emotional stimulation for the first 2 years of life. And clearly, the brain developed differently without that stimulation in the first 2 years of life. So we know that lack of stimulation and a stimulating environment for the child actually does affect the structure of the brain, which lasts for the entire life. This is from the Harvard Center on the Developing Child, and the other thing that we know is those pathways that are developing early are very critical. They're the sensory pathways for vision and hearing and language and even higher cognitive functions. So those very early years are the time that social emotional pathways and language and vision and hearing are hardwired in the child's brain. You all have seen this slide, I'm sure, before too, in that the brain develops during this time, during the first 5 years, a huge network of neural connections. It's not that at that point developing any more brain cells, but it's when the brain cells connect up into functional units. And the critical thing that happens during that time is that the units that are used are the ones that stay, and the others are actually pruned away. And so that it's that hardwiring of the brain where as the units are used, they are kept, and the ones that are not are pruned away. And that attachment is really the primary source of hardwiring the brain for social emotional function. You've heard it called the serve and return, the back and forth between a caregiver and the child, and that continual back and forth serve and return of emotional signals is what hardwires the brain for social emotional connections. You've all seen that with the mother cooing to her baby, the baby looking back at the mom, and it's that attachment that really is the basis of creating that appropriate hardwiring in the brain for social emotional development. This is just a list of attachment disorders. If you don't get that social emotional foundation built very early in the child's life, you can end up with a lot of problems later. And we see this in many of our kids that have now gotten to school age, in that they have poor coping, they have learning problems and behavior problems, particularly inability to form trust. They become aggressive with antisocial behavior and have many disorders just because they didn't form those social emotional pathways. Another thing to remember is that the brain is somewhat malleable up until the teenage years, but again, those social emotional pathways, which are the basis for cognitive function and other skills, really form in that first 5 years of life. So just a summary of what we knew at the time of Kids Now is that the brain is not mature at birth and continues to remodel and hardwire through the first 5 years of life, and that experiences are actually what create that hardwiring of the brain. There are critical periods of time in that first 5 years, and if the hardwiring doesn't happen then, the changes are irreversible. And again, it's the relationship between a caring adult and the child that programs that social emotional function. You'll see this referred to a lot in the more recent literature as the critical nature of the first 1,000 days that lay the foundation for the rest of life. The other thing to remember is this slide shows the spheres of influence for a child in their development, and you'll notice in less than age 5, the primary spheres of influence are still the family, as well as some daycare in the community. The school age becomes a major factor later, but birth to 5, the major influences for the child are the family and child care. So as the Early Childhood Authority that was established in Kids Now morphed into the Early Childhood Advisory Council, you can see that supporting families is still at the core of what we do, and again, because families are the major influence on those kids between birth and 5. So we talked about the critical nature, the critical time periods for development at birth to 5, particularly for brain development. The other thing to remember about what happens in the life course is that all of these arrows, both upward and downward, are in fact cumulative over time, and we know that more and more now. So that children who grow up with a lot of negative influences in their environment, such as poor nutrition, domestic violence, child abuse, drugs and alcohol in the family, poverty, all those things are stressors during the early childhood period, and again, those are cumulative and last through the rest of their lifetime. The best evidence of that really comes from a study at the CDC called the Adverse Childhood Experiences Study. This was a partnership between the CDC and the Kaiser Health Plan, and it's very striking in its results. The study looked at adults in the Kaiser Health Plan, so these were people who were employed and had insurance and were getting regular health care, and their average age was in their 50s. Over 70% of these people had some college education, and about 40% of them are college graduates. So this is a typical middle-class population. You can see that about 75% of them were white, another 5% African-American, and about 11% Hispanic. So what they did was when these people went for their annual physical and got a complete history and physical done, they sent them after that a questionnaire that asked, before you were 18, did you experience any of these things? And this is the list of adverse childhood experiences they asked about: physical abuse, emotional abuse, sexual abuse, domestic violence in the home, substance abuse in the home, mental illness in a parent, loss of a parent due to separation or divorce, or a household member in jail. So when they tallied up the responses from these 1,700 or so people, they found that adverse childhood experiences were extraordinarily common, which they did not expect. And particularly if you look at child abuse, physical abuse, almost a third of the people that responded to this survey had suffered physical abuse as a child. Substance abuse was common in 1 in 4 of these people. 1 in 8 had witnessed domestic violence. So very common experiences. So the researchers assigned 1 point for each of the different adverse childhood experiences that people had experienced. And you can see when they tallied these up, 2/3 of people had at least one adverse childhood experience in their life. And when you got up to 4 or more adverse childhood experiences, you began to see the effects on their health and their outcomes. These numbers correspond pretty well with an entirely different survey about children's exposure to violence. This was done in 2009 by the Defending Childhood Initiative, and you can see there that they found that 60% of American children were exposed to violence, crime, or abuse in their homes, schools, or communities, and about 40% had 2 or more violent acts, were direct victims. Very similar numbers to what they found in the ACEs study. The ACE study clearly now shows that chronic diseases in adults are determined decades earlier by experiences in early childhood. So again, early childhood matters not just for the time period of childhood, but for the rest of the person's life. All of the things on this slide have been associated with adverse early childhood experiences. We're going to go through 4 categories. One is health risk behaviors. And you can see that for teen pregnancy, the more adverse childhood experiences that a person experienced, the more likely they were to have had a teen pregnancy. Age of onset of smoking, the same thing. With no adverse childhood experiences, or 1 or 2, the percent was fairly low, but by the time you got to 4 or 5 adverse childhood experiences, early smoking was much more prevalent. In those children who had adverse childhood experiences, and as adults reported alcoholism, you can see that whether or not their parents were alcoholic, On the green lines are the parents who were alcoholics, and in the purple lines it's those whose parents were not alcoholics. Regardless of whether or not they had a parent who was an alcoholic, if they had more and more adverse childhood experiences, they were more likely to be alcoholic as adults. The same picture shows for illegal drugs. And again, with no adverse childhood experiences, people are very unlikely to get into illegal drugs in their teenage years. However, as the adverse childhood experiences increase, the likelihood of the person becoming a drug user in their teenage years increases significantly. And that's especially true for IV drug use. And this chart says that if you have 4 or more adverse childhood experiences, you are 3.5 times more likely to use IV drugs than the people with low or no ACEs. Now, the way the scientists interpret this is that these risky behaviors may just be manifestations of people who are trying to cope with the adverse childhood experiences that they have never been treated for, never been able to resolve their feelings about. And so for many of the people doing these adverse behaviors, it's not just making bad choices, it's the fact that that's their coping strategy for dealing with the way their life has been. And so we as clinicians try to say, well, they shouldn't be smoking or they shouldn't be drinking, which means we're taking away their coping mechanism and just makes it worse. So we have to think past that into what's really the underlying mechanism and try to address that before we really can resolve some of these issues. Very similar results we're seeing with mental health problems, as you might expect. For those people who had adverse childhood experiences, as adults, they were much more likely to suffer depression. And you can see this is broken down by women and men. And so that in women who had 4 or more adverse childhood experiences, again, in early childhood, over half of them suffered depression as an adult. You see the correlation here very clearly in suicide. This is the risk of ever attempting suicide. And again, for those who have very, very low adverse childhood experiences, there's very little risk of anybody attempting suicide. But as the adverse childhood experiences mount and go up to 4 or 5 or greater, you can see the risk of attempting suicide. The percentage of people who do as adults rises significantly. And even if we look just at teens, particularly those teenagers who have had 6 or more adverse childhood experiences are much more likely to have attempted suicide as teenagers less than age 18. Another interesting thing that the researchers found was that hallucinations are more common in people who have had more adverse childhood experiences. Now, as a pediatrician, when we see kids with hallucinations, obviously our first thought is that they have using drugs or alcohol. And so you can see that this slide is split up into those who did use drugs or alcohol and those who didn't. And again, even for people who were not using drugs or alcohol, hallucinations were much more common when you had 4 or more adverse childhood experiences. So again, the question is, are these hallucinations really just ways of dealing with the stress from those adverse childhood experiences? And should we treat them differently because of that? Adult disease and disability are clearly now associated with these adverse childhood experiences. We have a whole list of chronic health conditions that are seen more commonly in people who have had adverse childhood experiences. It's not a surprise that HIV and sexually transmitted diseases are more common in people with adverse childhood experiences based on what we learned earlier about the high-risk behaviors and adverse childhood experiences. And this is, you can also see that smoking and lung disease, with or without smoking, are more common in people who have suffered 4 or more adverse childhood experiences. Coronary artery disease, again, more common in those who have had 4 or more adverse childhood experiences. Their risk of coronary artery disease is about 1.5 times the normal population. And even obesity, the odds ratio of an adult being obese is doubled if they have 4 or more adverse childhood experiences. So you can see that these adverse childhood experiences affect a lot of a person's life as an adult. And even if you don't attribute a lot of disease to the adverse childhood experiences, people who have suffered adverse childhood experiences are much more likely to have social problems. The risk of being a victim of domestic violence If a woman had 5 or more ACEs, she is 500 times more likely to become a victim of domestic violence. And even remember that the people in this study were people who had jobs and had health insurance and were receiving health care. But even though that they were working, it was clear that the people who had more adverse childhood experiences had more absenteeism, more financial problems, and just problems getting along with people on the job. Again, probably because their brain development was affected by these adverse childhood experiences. And when they looked at a subsample of this population and identified people who had died, people with 6 or more ACEs died 20 years earlier than those who had less than that. So Dr. Folletti, who's one of the original authors of this study, has said that over half of all depression is attributable to adverse childhood experiences, 58% of suicide attempts, 65% of alcoholism, and almost 80% of IV drug use can be attributed to these adverse childhood experiences. So Dr. Folletti says that the adverse childhood experiences that we now can identify are the most basic and long-lasting cause of health risk behaviors, of mental illness, of social malfunction, of disease, disability, of death, and health care costs. So that's a huge statement and speaks to the importance of childhood in terms of the whole life outcome. So you can see this is the pyramid that they use, in that the base of it is the adverse childhood experiences. Those become built into the child's development, neurodevelopment, and that impairs their cognitive and social development, and that leads to the adaptation of high-risk behaviors and to disease and disability and early death. So here's a clinical application of how those adverse childhood experiences have been used in real life. In Washington State, they have done a survey of many of their schools to ask children about their adverse childhood experiences. And they developed a profile of a typical classroom in Washington State. And the typical classroom, you see here, would have about 30 students. And of those, you would have about 6 students with no ACEs and about 5 students with 1 ACE, and another 6 with about 2 ACEs. But if you look at the other end of the spectrum, you have 7 students with 4 or 5 ACEs and 3 students with 6 or more ACEs. So 10 out of your 30 students are likely to be having serious behavior problems and health problems due to their adverse childhood experiences. So with all these adverse childhood experiences early in childhood, they build up over time and they accumulate. This cumulative risk leads to worse health outcomes. So now we know a little bit of the science behind how that really happens. This again is from the Harvard Center on the Developing Child, and it says that the research on the biology of stress illustrates that it raises the heart rate, blood pressure, and stress hormone levels. And those can impair the actual architecture of the brain, as well as immune status, metabolic systems, and cardiovascular function. So this toxic stress now has been well described. These are a couple of the articles in the last year from the pediatric literature. And it's really pointing out that pediatricians and all kinds of child care providers need to be more aware of toxic stress and what it can do to children. So there are 3 levels of stress that are described in those articles and by the Harvard Center for the Developing Child. One is positive stress. And you all know that all of our lives have some stresses in them, and that's not always a bad thing. Preparing for a test is positive stress because it makes you concentrate more. However, once you've passed the test, then it certainly builds your self-confidence. We have tests all the time that are positive stress. When a child first learns to ride a bike and falls off, and we encourage him to get back on and learn. That's how you learn, is by going through stressful situations and learning from them. So not all stress is bad. Tolerable stress, though, is a higher level of stress. And we see that, for instance, with the loss of a loved one, the death of a grandmother, or something like that in the child's life that is more serious, more intense, but usually very temporary. And the way kids get through that is to have a caring adult who will help talk them through that and reassure them. And then there's toxic stress. Toxic stress is where the stress is more intense and more prolonged, and these stress responses that are a normal part of the way our body functions remain elevated for too long and actually damage the brain architecture. So the parts of the brain here, you don't need, this is not going to be on the test, but the parts of the brain most affected are the limbic system, where you have the amygdala and the hippocampus. And the amygdala is considered kind of like the brake, the gas pedal, and the hippocampus is more like the brake and the prefrontal cortex. But we actually know these sites in the brain. So you all have experienced, I'm sure, at some time in your life, the fight or flight response that is normal for our bodies to deal with stress. You come up upon a danger or a stressful situation, that signals things in your brain and it releases the stress hormones. It elevates your heart rate, you breathe more rapidly, more blood flows to your muscles, and you run. The problem is, after that stress goes away, all that's supposed to shut down and you're supposed to go back to normal. And what happens in toxic stress is that we never get that shut off, and the body systems never go back to normal. You can see from this slide that if the stress, if you see the first curve, the stress goes up to alarm, but then it goes back down to normal. And even more intense stresses like fear or terror, for instance, 911, or some of the floods that kids have been through. There are more severe stress, but with normal supports, those things can also go back down to normal. And what happens for kids with toxic stress is you have very high levels of stress, and these traumas come one right after another. I mean, picture a child who lives in a home with domestic violence or substance abuse, and they're, hiding under a table as they watch their mother being hit. And it doesn't just happen one time, but it happens day after day. And you can see that their baseline never goes back to normal, and they remain with those elevated levels of stress hormones, which then damage the body. So we've known for quite some time that these elevated levels of cortisol and stress hormones can really affect the child's physiology. And we know that from the studies of those Romanian orphans, like that first brain slide that you saw. Their brains are smaller and their structure is different. So even though the children may be outwardly pretty normal looking, inwardly they may have significant changes in their brain structure and function. So the American Academy of Pediatrics really has been emphasizing this, and remember that this strong, frequent, or prolonged activation of the stress systems is most toxic when there is no supportive adult around to buffer that relationship. And if the architecture is disrupted, then you have a weak foundation for learning, for behavior, and for executive function. So it's quite obvious then how this strong association between these adverse experiences and subsequent problems in school functioning, in linguistic and cognitive and social emotional skills, they're all related to that hardwiring of the brain that in toxic stress gets disrupted. These are just some pictures, again, from the Harvard Center of the Developing Child. What's different between the normal brain and the outbreakings of the typical neurons and connections. And in a high-stress situation where there's toxic stress, I mean, it looks like almost frayed wires, and those wires don't connect up well. So, again, the AAP emphasizes that having a caring adult and a responsive adult is what reduces the risk that the toxic stress will lead to long-term physiologic harm and changes in the brain architecture. This is just a slide that demonstrates those elevated stress levels in children in poverty. The red bars are the children in poverty, and the yellow bars are children of middle income. And they measured these 3 different stress hormones after an overnight fast. And these are children who live in poverty and have that chronic stress. There was no acute stress going on during this time. But clearly they have elevated levels of these stress hormones day to day. Just for interest, let me show you these 3 centers of the brain that are associated with anxiety and fear. Again, this starts as a fight or flight type of action. So the 3 main centers are the amygdala, which again is the trigger point and the gas pedal for all of this, and the hippocampus and the prefrontal cortex, which tend to slow the reactions down. Those are the same centers in the brain that are associated with memory and learning. And in fact, they're the same centers in the brain that are associated with cognitive, emotional, and social capabilities. So all those things are happening in those same centers. So it's easy to see how toxic stress can really disrupt brain development for these kids.
If you're able to, if not, I can get it.
So all the things that are going on in the child's environment, not just what's happening in the immediate home, but in the neighborhoods and in the communities, all of those things have an impact on the child's development and the child's stress levels. For instance, children who can't go out and play because there's too many gunshots in the neighborhood or drug deals going down. I mean, that's a chronic stress that the child has to deal with.
753-3381, I believe. Here, let's see.
Just a quick reminder, if you could go ahead and mute your phones, you can also hit *6 and the system will mute for you.
753-3381.
I'm not sure who is unmuted, but if you could go ahead and mute your phone for us.
Okay, so we'll move on. So the good news about this toxic stress and what it does to children and the fact that childhood experiences last a lifetime, the good news in this science is that there are things that we know we can do to make it better for children. We've talked about that trajectory of health and development being a balance of risk factors and protective factors. And traditionally, particularly from a health point of view, we have always focused on trying to reduce those risk factors. And for 30 years, we've been working with the same risk factors, and we've not really gotten very far. What we found is that if we build protective factors, we're much more successful in improving our outcomes. And I think the classic program that we've seen that does that is the HANDS program, where it's a very strengths-based program. It builds protective factors in the families. It helps build the family functioning and teaches them to deal with the challenges that they have every day. It helps them deal with problem solving and setting goals and learning to resource the goals and anger management. So they do a lot to improve family functioning and build protective factors. And as a result, we see better health outcomes even though their health care is not really any different. So we have this balance between risk factors and protective factors. And if the balance is weighted toward the risk factors, then we have what we call negative vulnerability. If it's weighted on the side towards protective factors, we see positive resilience, or the ability to bounce back. And so we see now a continuum of those families that are weighted down with risk factors are more likely to see child abuse in their families. And on the other side, the families that are more weighted with protective factors are more likely to see school readiness. So we see this continuum going from child abuse to school readiness, and in between, on that continuum, is the level of family skills and support. Now, those are things that we can certainly intervene and help with. So again, resilience is that ability to bounce back. This is just from a couple weeks ago. Coach Nick Saban from Alabama was talking about the resilience of his football team when they were behind 14-0 and came out with a win. This is obviously not last week, but the Cardinals had won that same week. This is in September. On resilience, the ability to bounce back. And so it's something that we try to teach at all ages, and it's particularly important in young children who are experiencing those adverse childhood experiences. So if we look at the three things that we've talked about, one is the hardwiring of the brain and that initial secure attachment. Again, if we just look at that in terms of the risk and protective factors, if we're on the protective factor side, we see that those kids who establish secure attachment, they have trusting relationships with adults. They're willing to explore their environment. That's the approaches to learning that you see in our school readiness definition. They can tolerate disappointments. They can stay on task. They can form friendships and networks of support. Whereas kids who never got that secure attachment, they have poor coping skills. They have learning delays and behavior problems, speech and language delays. They have a difficult time forming relationships with people and trusting people. And that ends up resulting in aggression and violence and antisocial behavior. Sometimes they have eating disorders, and they may be misdiagnosed as psychiatric disorders. If we look at the toxic stress that we've talked about, again, on the protective factor side, if you're able to mitigate that toxic stress by having caring adults who can help you through those times, you maintain problem solving and self-control. You learn to calm yourself down because you have an adult there that's taught you how to do that. And you're able to persist on task. You don't get easily provoked, and you can manage yourself when somebody tries to provoke your temper. You can delay gratification, and you have the ability to plan what might be coming next because you've been in a predictable environment. And for those who are under chronic stress, with toxic stress, then you get this impaired memory, particularly working memory. And any of you who have been through even an acute stress, short-term stress, like losing a loved one, you know you don't remember things as well during that week or couple weeks, and sometimes longer after that. Again, because the amygdala has taken over. You have that inability to concentrate, so these kids can't sit down and focus on something. They wander from place to place. They don't follow directions well. These are not kids necessarily with ADHD. These are kids who are under chronic stress. And so if we measure that in terms of ACEs, the adverse childhood experiences, again, on the protective factor side, if you have a low number of adverse childhood experiences, you're more likely to have good mental health and normal growth and development. You're less likely to have chronic disease, less likely to use tobacco and drugs, more likely to have school readiness and success in life, and more likely to have secure employment. If you have 4 or more ACEs, then those people are more likely to have tobacco use, particularly early tobacco use, drug abuse, particularly IV drug abuse. They're more likely to be obese, have heart disease, have teen pregnancies. They have many risk-taking behaviors. They generally don't form social networks. They have a high risk for school failure. This is where they get into gang membership because they don't form relationships well. And they have difficulties on the job, as we saw in the ACE studies. And so we have this, again, this balance between risk factors and protective factors. We can actually see from the physiology of what goes on with adverse childhood experiences and toxic stress. So what can we do about it? Well, we can work on these family skills and support that will push families towards school readiness and positive resilience. So ACEs can last a lifetime, but there are ways to improve that. So our vision is that all children should be nurtured, supported, and protected in safe and stable environments in their homes and communities. That families should recognize the rewards and responsibilities of raising children, but most importantly, they should have access to support within their own communities to help them meet those responsibilities. Families should be able to ask for and receive timely assistance without the fear of being punished or blamed. We don't want any stigma associated with people reaching out for help. And communities should be supported in their efforts to meet the diverse needs of families raising their children. So there actually is science, again, behind this as well. And the Center for the Study of Social Policy has determined a program called Strengthening Families, which has studied which protective factors are the most likely to make a difference for our families. Again, the approach is that all families, because we know that all families go through periods of stress, and the idea is that every parent should be supported in their community in their efforts to be a good parent. This builds on family strengths. It buffers those risks and those toxic stresses, and it promotes better outcomes. It's not really a whole program, a separate program from what people are doing, but it's a way to build protective factors into the things that you do every day. It is grounded in research. This was actually funded research by the Annie Casey Foundation through the Center for Science of the Study of Social Policy. And it creates a common language that we hope will become prevalent across all of our community programs that meet families wherever they are. So there are 6 protective factors, one being nurturing relationships, and we've talked over several times about how important those nurturing relationships are. Then there's parental resilience, again, the ability for the parents to bounce back, social connections, knowledge of parenting and child development, concrete supports in time of need, and the social emotional competence of children. So the idea of strengthening families is that no matter where the family goes in the community, they will feel supported and have these protective factors that are encouraged and built into their daily life. So that when they go to the pediatrician, it may be about physical health, but the pediatrician should know to also ask about some of those protective factors. At family resource centers, they might be emphasizing the concrete supports in time of need and how you hook up with those. In domestic violence, they're going to be talking about parental resilience and how do you learn to bounce back. So the idea is that everywhere in the community, people are working on these protective factors and helping families build protective factors that will help them balance against the stressors that they're put under every day. So this Strengthening Families, again, is a national program approach. It's endorsed by the Children's Bureau with the Administration for Children, Youth, and Families. It's endorsed by the Office of Head Start and the Office of Child Care in ACF, the Maternal Child Health Bureau, SAMHSA, the Substance Abuse and Mental Health Administration, and the Department of Defense. And you can see many other partners that are involved in this at a national level. There are many states that are working on this Strengthening Families approach, and Kentucky will soon be turning to green to join these 37 other states working on strengthening families. So we're going to go through real quickly now just, again, the protective factors and the kinds of things that you will recognize in the work that you do every day. The first one is nurturing relationships, and the CDC refers to this as safe, stable, and nurturing relationships and environments. And the idea is that safe, your environment should be free from harm. Stable means a high degree of consistency. In order to learn predictability, children have to have consistency in their day. And nurturing, there needs to be a compassionate and responsive caregiver. Now, nurturing relationships are important not only for the child, but for the parent as well. Because in many cases, parents are unable to provide this for their child because they've not seen this modeled. And so programs that help mentor parents and believe in parents also help with nurturing relationships that will eventually result in better outcomes for the child. Sorry, these slides got shifted up when they were loaded, but resilience is having good outcomes in spite of serious challenges, and they call it the ability to bounce back. So part of that comes from feeling connected, both to your family, to your community, to learn those self-regulation skills, which again are something we can teach if that's something that parents don't feel equipped that they have. Having a positive view of self, and again, having somebody to believe in you, and the motivation that you can be effective in your environment. So we teach parents that they all want to be good parents, and if they don't have the skills they need to be good parents, that's something that we can help them with to help build parental resilience. Knowledge of parenting and child development is extremely important because many times things like child abuse are triggered because a parent has inappropriate expectations of their child for that developmental stage. So in many communities, we have 3 sites now in Kentucky that are working on Help Me Grow, which is a telephone-based developmental screening, which will give parents instructions on what the appropriate expectations are for their child at any age. But it's very important for parents to understand because many times you don't want them to punish a child for something that's really normal behavior for that age child. And so it helps reduce the frustrations of the parents as well as the child if we can teach parents what normal behavior is. So some of the steps are just educate parents on what to expect next, model and teach positive ways to manage challenging behaviors. Routines are particularly important for young kids. Again, that predictability of knowing what's going to happen really helps them develop their social emotional skills. Parenting classes are quite useful for parents, but you need to have supports both before and after the parenting classes to make sure that parents can keep those skills up. The signs and symptoms of child abuse are something that every provider to families of young children should certainly understand and be able to recognize so we can identify these families and children at risk. And it's a good thing for providers to know about the adverse childhood experiences and what that does to people. And many times the behaviors that we look at in children and the things that we're seeing in the adults may be related to adverse childhood experiences so that we can approach those differently and not be critical. Social connections is another one of the protective factors. And everyone needs a network of emotionally supportive friends, family, and neighbors. It helps with parenting. Clearly, there are many nights that you feel like you're all alone at 2 in the morning when the baby's crying and you at your wit's end. You need to have somebody you can call or somebody who can give you guidance. This feeling of isolation is really terrible for parents to go through. They need to feel like they're connected to a supportive community. And children, too, need access to not just one person, but to a supportive community and to see positive role models. So to help build social connections, one of the things that agencies can do is to look at what parents already have in place for their social connections and to try to enhance that network of support that the parent may have or may not have at all. Faith-based communities are extremely helpful in this and providing opportunities for parents to get together and share about their skills and their interests. Concrete supports in time of need. We all know that this is a protective factor because you can't do much else in life if you don't have a roof over your head and food to eat. So if we don't address these concrete needs, then we may not be able to address the other needs that the family has. For most agencies, that's not going to be actually providing the food or shelter, but it's being able to hook families up with places where they can get it. I would also encourage you now with the new Health Benefits Exchange in Kentucky that if you don't know where that's done in your community, you find out, because getting people coverage for health care insurance is a really big deal for many, many families. And most of the time, the places that they will get their benefits will give free preventative care or preventative care at no charge to families. And so now that's an opportunity that we've not had in the past. So I would encourage you, if you don't know where in your community people can sign up for the Health Benefits Exchange, that you figure that out so you can refer families. And building social-emotional competence. Again, this whole thing is based on the social-emotional pathways in the brain that are hardwired in those first few years. That becomes the basis for the child's cognitive development, so their math and their reading skills. But perhaps more importantly, it's also the basis for these non-cognitive skills now that James Heckman and other people are talking about, in terms of just persistence, the ability to stay on task, self-control, curiosity, the ability to calm yourself down. Those are all things that are still built on those social-emotional pathways that are hardwired in the first couple of years of life and are based on that secure attachment. So it's really important that we focus on that early in the child's life. Some of the ways to do that in a real setting are to observe and attend and listen to children and be responsive to them, provide a safe and stable home life, to model caring behavior. Again, responding to the child's needs is a big deal. We should not let kids, if they have real needs, not get a response to that. And to reinforce the child's strengths. So much of protective factors is about building strengths in children and in families. And if we can do that, we think we can be successful in helping them better cope with the challenges that they have. This is a vision for our children and families, is that there should be an intentional set of services for families, beginning with a strong foundation of support for every parent and child that's available when the child is born or even when the woman is pregnant. Keep in mind that we know the periods of time that families go through stressors, and we should be able to provide supports for families, and families should be able to ask for help during those times when we know that there are challenges to the family system. So for many of us who have worked at agencies for years, there's a paradigm shift that we need to be thinking about. We have thought for many years about the at-risk families, but based on the ACEs study, where 2/3 of all people have at least one adverse childhood experience and 40% have two or more, we need to be thinking about framing what we're doing for all families. Because again, all families go through periods of stressors, and it's likely that in most families there will be people who have had adverse childhood experiences. Again, we're shifting from thinking of risk factors and focusing on risks and deficits to protective factors, because the protective factors are what's going to buffer the toxic stressors and challenges that these families have to face. We have focused in the past on deficits, what the family can't do, and I think we'll be more successful when we move to a strengths-based model where we look at what families can do. And if the families are unable to do some of the skills that we think they need, then I think our role is to build those skills. And so if the parenting is not what we'd like it to be, we can help build parenting skills for these families and make their lives better. And so our focus on prevention is really more now about promoting strong families and healthy development. rather than just trying to prevent terrible things from happening in these families. I'm going to skip that. So since you all are early childhood people, you already know this, but the Harvard Center for the Developing Child says, the healthy development of children is what provides the strong foundation for a healthy and competent adulthood, responsible citizenship, economic productivity, strong communities, and a sustainable society. And many times you will see the return on investment for early childhood programs be framed in terms of the benefit to society more so than the benefit to the individuals. So these are all things that we can work on and things that we can do. I think the science is explaining a lot of the things that we were unable to understand in the past. And clearly we know enough now to do better with our interventions and to work on protective factors to overbalance the challenges that families face in their everyday lives. So I think at this point we will stop and take questions.
And you can either use the chat box on the left-hand side of your screen to ask a question or unmute and ask over the conference call line.
Dr. Shepard, how will this be addressed within the Cabinet for Health and Family Services as far as the removing children from homes and then the constant moving from one placement to another, sometimes within a very short period of time? What's the vision for supporting the Cabinet and supporting families and children this way?
That's an excellent question, and I will tell you that there is we have a work group now within the Cabinet that's working on strengthening families, and the DPP folks are involved, and several of the folks from, actually from all of our agencies, are involved in discussions of how do we take this strengthening families and protective factors model and build that into our everyday work in terms of our policies and procedures. And I think clearly knowing that separation from a parent is one of those adverse childhood experiences. These kids that go through multiple foster placements are really at risk. And there is a separate work group also working on how to reduce the number of placements that these kids go through. So I think it's something the Cabinet is aware of and we're working on. I don't think we're to an answer yet, but I think the study of adverse childhood experiences makes it even more urgent that we do something to reduce those multiple placements and try to keep these kids in a more stable environment.
Thank you.
Dr. Shepard, how do you see the community early childhood councils playing into the strengthening families model?
Well, thanks, Amanda. I think there are a number of things that community early childhood councils can do. And I actually see the community early childhood councils as maybe being the conveners in each community with the focus on early childhood, because that's where this is most important. In terms of developing these discussions, things like parent cafes about the strengthening the protective factors and how your community would define those, and then what each of the agencies in that community could do to help promote those protective factors. So I see the early childhood councils as being kind of the conveners of this discussion in their communities, because it's critical in early childhood, probably more so than for the older school age kids.
Looks like we do have a couple of questions coming up via chat. And so the question is, in some cases, a child's teacher is that caring adult. How do we help train teachers about the framework, and how do we equip them with the necessary skill set to help children even more?
Again, another really good question, and absolutely those teachers and teachers in child cares are often the person that child attaches to and can really model for that child and help that child through some of those social emotional skills and getting those built in. So there are discussions with the Department of Education about this, and there's also some information coming from the Department for Behavioral Health on trauma-informed care, which is to really learn to address these kids as if they've been through these traumas, because we know in most cases that will be true. And so there are trauma-informed care trainings that are already being done in the COP care centers, and we hope within the next year to translate those into trainings for educators as well. There will be some things that there's an upcoming conference on exceptional children, and there'll be some discussion of it there. And I think there's also a conference next summer about social and emotional development and how teachers can address that. So all of those things are starting to incorporate some of this language, and there will be specific trainings coming out, we think, within the next year to help teachers learn how to address this and deal with the toxic stressors and adverse childhood experiences.
Maybe another question via chat. Okay, well, I would like to, on behalf of the Governor's Office of Early Childhood and CECCs across the state, thank Dr. Shepard for coming in and talking to us about toxic stress this afternoon. As usual, we will be sending out a YouTube link with all of this information for you and your CECCs. Our office does believe that the Strengthening Families model and the toxic stress, alleviating toxic stress in communities is going to be really key to moving the needle forward for children across the Commonwealth. So are there any last questions?
I do have one more question, and it kind of goes along with other community supports out there, but within child care settings, you know, oftentimes, because I'm from within First Steps, we get referrals for behavior. That's the #1 referral we get. And oftentimes, by the time we get it, it's the child's being ready to be expelled. But oftentimes, too, in those centers, the caregivers are adults who have had adverse childhood experiences. So what's the plan to help support those adults deal with those children that come to them?
Well, I think a big part of this, the reason that all the agencies are pulling together on strengthening families is because we all see it as an opportunity to deal with this in multiple levels. And one of the big pieces of this is going to be the professional development piece, and that's going to involve child care in schools and First Steps and Hands and all of those agencies. And the goal would be to build in professional development that would educate all of those people on how to better use protective factors in their work. As far as addressing the adverse childhood experiences with the workers themselves, I think that's part of the trauma-informed care initiative, and that's something that, you know, as the agencies take this up, I think that's something that agency leadership is going to have to address is, you know, how can we expect child care workers to model some of these things when they've never seen it modeled themselves or when they've been through adverse childhood experiences that have never been dealt with. So I think it's an excellent point and something that professional development will be a big piece of this strengthening families as we move forward with it.
Thank you.
Hey everybody, thanks again for taking the time out this afternoon to join us on the webinar. As I said, we'll be sending out a YouTube link. We hope you guys gained a lot of information this afternoon, and this is going to help guide a lot of what we're going to be talking about through our office for the next year. So, you know, we want to make sure that the toxic stress becomes a very important key part to what CECCs do across the state. So. With that, I will let you guys go. Thank you so much for joining us this afternoon, and I hope to talk to you soon.